My name is Tony Aldave. I'm a corneal specialist at the Stein Eye Institute in Los Angeles, California. I am not GN Rao. I wish I were. But I understand he's not here. He's the chair of this session, and so in his place as co-chair, I will moderate. We have a great session. Sorry, we're starting a little bit late, but we will finish on time. I do want to make sure, though, we have time for a couple of questions after each presentation. We'll try to limit the questions to about 2 minutes. If we do that, we'll be able to finish on time. Our first speaker, Jod Mehta. Jaw is probably getting sore given all the talks that he has at this conference. Coming to us, obviously, from Singapore National Eye Center. He's going to be starting off this session with a talk entitled DALK in 2024.
Great. Thank you, Tony. So thanks for the invitation to talk in this session. So I'm going to be talking about the way we do DALK now in 2024. So these are my disclosures really pertaining to ZIMA, which we'll basically be talking about in a bit more detail. So lamellar surgery has become the gold standard in surgery across the world, really, for EK replacement with DMEC or DSEC, and for anterior lamellar capacity, basically with DALK. But the rates of DALK vary around the world, as you can see from data from EBA at the top, and data from Singapore Corneal Transplant Database below as well. And in Singapore, about 30% of all my cases are basically done with DALK. And really, to increase the rates of DALK worldwide, we need to basically de-skill the procedure. So a few years back, people talked about using a femtosecond laser for the procedure, and you can have all these fancy cuts around the edge of the side cut angle for the laser, and it's been shown to sort of give you better wound strength and allow you to take these sutures out early. But interestingly, in the longer term, once the suture is actually all removed, despite the fact you get better apposition and alignment, actually the astigmatism results actually come back to being very quite similar to what you see from normal full thickness or partial thickness transplantation. And the problem with all these publications that you see where we use femtosecond laser assisted keratoplasty is that following the rim cut, you still have to make a tunnel to insert the cannula to get the big bubble. So it kind of makes it nice that you get a nice incision with the apposition, but it doesn't help you basically to get the big bubble, which is probably the ultimate goal for most of us when we're basically doing DALK surgery. So a few years back, we're using the Z8 femtosecond laser, which is a low-energy nanojoule laser system. We developed a program with ZIMA in order to make the tunnel intraoperatively at the same time that you basically do the DALK procedure, and this was using the intraoperative OCT. This just basically shows you how this basically works. On the left-hand side is some animal eyes that we basically did. On the right-hand side is a human donor study. And we optimized the system basically on pig eyes with respect to the lamellar cut and also basically the tunnel cut. And then we basically tried this on human donor eyes to basically show that we could get the bubble. And when you look at the histology and basically also on the OCT, you can see you get a nice big bubble basically in these corneal samples in these human cadaver eyes. We then went on to do a series in collaboration with Theo Seiler in Europe. And these are basically some of the first cases that were published back in 2019. So we did about 14 cases, a mixture of pathologies, mainly keratoconus, a few scars. And so you can see on the video the intraoperative OCT now coming up into alignment. And this allows you to set the tunnel depth exactly between about 50 to 80 microns away from descemet's membrane. So you get a very good accuracy. Now, this is done with a flat applanating system on the Z8 currently. So that's why you see those posterior folds in descemet's membrane itself when you're basically doing the surgery. But once you basically done the applanation, you then basically fire the laser. It does the tunnel cut first, and then it does the side cut basically onto the surface. So you can see it basically occurring now. So once it's fired the tunnel, it'll then basically do the vertical rim cut all the way across basically up to the surface. So it does a lamellar patch, and then basically all the way basically up to the surface to the epithelium. And then you can cut the donor tissue either with a standard Trefine or basically with a the femtosecond laser as well, whichever you basically want to do. So then all you have to do is basically peel off basically the anterior lamella. It's often slightly sticky where basically there's a scar, and then you'll see there's a track there. So the track, you basically put your DALK cannula into itself, and then basically you inject, and then you hopefully will get a big bubble. There you go. Okay, so you get a bubble basically formed. So in the series of about 14 cases from the first publication with this tunnel, we had about 3 cases of basically rupture during the dissection, ironically not during the bubble formation, and these were all successfully completed itself. So following our publication, there were two other papers, one using the Victus femtosecond laser. We're giving you a straight edge cut, and they were able to get big bubble in 100% of their cases in a small series, I think about 15 to 18 cases. And Boris published a series from Russia, basically showing that by using the intraoperative tunnel guidance, he was able to improve his success rate of big bubble formation from 36% to basically 65%, but also importantly reduces the conversion rate to penetrating capacity from 15% down to basically 7%. But you know, we also know from the literature that actually if we could change the shape profile of the graft from a straight cut to a mushroom cut, this would also be advantageous because basically we can improve the refractive outcome basically from our patients. But the tricky thing is that how do you combine both of these technologies together? So i.e. a mushroom and basically the sort of disruptive technology, which is basically the tunnel cut on the same side as well. So we thought this was basically an important thing to try, so we tried to basically do this with laser. So the laser has to move twice now in order to basically get this cut basically to find itself. And we know the importance of basically of doing this because it allows you to suture your graft well away from desmoid membrane. And we know from our publication that basically 27% of all perforations or microperforations occur during basically the suturing. So we went back to the wet lab again with some pig eyes back in 2022, and we came up with a software basically in order to basically do this on the Z8 femtosecond laser. This is the first patient that underwent the surgery, 53-year-old Chinese lady who had cross-linking on her right eye, left eye contact lens intolerant. You can see basically for 16 diopters of irregular astigmatism on the corneal surface, and she underwent a left mushroom dock. This laser itself is basically docked onto the surface, similar to basically what I showed you, but now the laser head's going to move twice in order to basically get the mushroom cut. So the intraoperative OCT allows you to set basically the end of the tunnel to 50 microns away, which is what I do from all my cases now, away from desmoid membrane, and you can change basically the angulation of basically the tunnel depth itself. So I do use a 400 micron width tunnel, well not 600, which is what Zima recommended initially, and this seems to give you the optimal profile with respect to getting a big bubble. So now it's doing the lamellar cut, which is typically about 200 microns away from desmoid membrane, so 150 microns away from the tunnel, and now we're basically going to do the side cut around the whole thing. The whole thing takes about 35 to 40 seconds to do the laser cut, but it does take a little bit of time to do the program, which you can do basically before the surgery itself. So once the basic laser is cut on the surface, you simply just basically peel off the surface from the edge. So there you go, so you peel off the surface from the edge, and then you've got your hole there on the surface. This is I open it with a Sinskey hook. So this is my tunnel hole. You simply just put your cannula in to that basically hole. So I use the Donald Tan cannula with a hole at the bottom, and you basically inject basically to get the big bubble. There you get the big bubble, and you only have to go out to basically 6.5 millimeters basically from the surface. So this is the result basically. Afterwards you get a nice regular profile on the surface and a very even topography profile, obviously because you've got the mushroom cut. So obviously that's an easy case because it's keratoconus, the cornea is clear, but we've done it for avulino corneal dystrophy, and I've also done it for mucopurulent sarcoidosis as well, and the laser will basically cut through these corneas very well as well in order to basically get these mushroom cuts. So I'll show you a bit more complicated case. It's a 19-year-old boy where you can see that previous scar on the cornea itself, and he has basically a 76 diopter cone as well. And again with the laser, this shows you the big advantage of having the intraoperative OCT, because you'll see that once we basically applicate the laser onto the surface, you will see, so I'm just showing you the scarring here on the OCT to show you how deep it is. But you can see this on the intraoperative OCT. So what I can do is I can set the edge of my tunnel just before you basically see the scarring depth on the surface there itself. And this allows you to the movement from the tunnel on the OCT to know exactly where the tunnel is basically going to be. So you can see the scar basically on the surface. So once we basically set the depth again, we do very consistent 50 microns away from desmoid membranes from the folds there. You'll see that they're dropping down the lamellar cut across the surface to keep it about 150 to 200 microns away from desmoids. If you do a keratoconic case, you must do the recipient first and then do the donor. Don't do it the other way around. Okay, so when the laser's firing, you can see it's firing the tunnel. Now it's a horizontal cut, and now it's basically doing the mushroom side, and then basically it's doing the vertical cut on the edge. Then it's basically going to laser up to the surface. And you can imagine when we basically peel off the surface now, obviously where there's a bit of a tag, basically the scar there, you'll have to basically dissect it a little bit. So as you see, I open up the edges first of all, so you gently peel the surface, and it's cut through the scar pretty well, actually. I mean, I'm just basically just gently manipulating that with a Sinskey hook to remove any of the basically remaining tags. So once this is basically released from the surface, Then you have your tunnel there, and then you just put your cannula inside the tunnel that's already been basically pre-created basically beforehand. Sometimes people find it difficult to find a tunnel. If you use a Sinskey hook, it'll help you basically open up at the beginning. So once you put your cannula in, it's right at the point just underneath where that scar was, and I was able to predict that from basically the OCT, and then you can see the bubble formation, and the rest of the surgery is basically routine as normal. This is basically the post-op, but this is that 1 month post-op. I've never seen visions as good as this in all the dog surgery I've done at 1 month post-op with this technique. So conclusion, the use of femtosecond laser and keratoplasty has shown some advantages, but the introduction of intraoperative guided tunnel is really a disruptive technology in the field. The use of mushroom dog with the tunnel offers the advantage of a tunnel creation optimal profile itself, and DOLC in 2024 is mushroom with an intraoperative OCT guided tunnel. Thank you for your attention.
We have time for a question or two from the audience. Do we have any questions for Judd? I have a couple. One is the creation of the tunnel.
Yeah.
What's the width? Because it seems like if you're inserting, what's the gauge cannula you're using, that if
Yeah.
it's too wide, of course, you're going to have just reflux of air and you're not going to get a big
Absolutely.
bubble.
Yeah, that's correct. So initially that's why initially we basically optimized it on the animal. So we use basically 0.4 millimeter, but you can set it to any width of the cannula that you want itself. So with Donald's cannula, basically 0.5 fits absolutely perfectly. So I haven't tried any other cannulas, but you can optimize it to whichever cannula you want. But 0.5 is what 0.4 is what I use on all the cases for the width.
And that leads to the second question I had, which was, and you actually touched on it, is it hard to find the tunnel? Because many times I'll make a track with a dissector, then I go back with my cannula, and I can't find my damn track that I just made with my dissector.
Yeah.
And so if you have such a small tunnel, you mentioned you can use a Sinskey hook to try to identify it if you're having trouble.
So the key advantage is, so with the non-laser cases, the trick there is I always basically use a felt tip pen on the thing to make the track, then you can always pick it. Here with the laser, so I didn't show the Avellino case, but the Avellino case, you look at the scar, you think you can't see it. But actually, it's easy because you know where the tunnel entrance is in relation to the change in your mushroom profile, because you know that from the laser you see, because that's fixed position. So you know that. So basically, using the Sinskey hook basically will help. Someone else told me something that I haven't tried, which they said that if you peel the cornea in the reverse direction from inferior to superior, apparently they said it's maybe a little bit easier. But so far, I have been able to find the tunnels, and using the Sinskey, I think, is quite a nice little thing, just to open up the tip and then put your cannula in.
Very good.
Sorry. Have you tried without doing the bubble? Have you just
a mushroom? Yeah. So I have a case with a high drops case where I just do the mushroom cut, and basically I just don't do the tunnel. But the advantage is it takes away like the first bit, like half an hour of the surgery, down to like basically 45 seconds. You can just simply bit it back, and then I just do a manual dissection, so I don't do the thing. The downside of this technology currently is that, of course, it's using a flat applanator. That's why you see those curves. So we have a new software now, which is a liquid applanator, hopefully to do exactly the same thing.
Thank you very much. Our next speaker is Dr. Audrey Rostov, who will be speaking to us on DMEC versus DSEC case selection.
Thank you. It's a pleasure to be here. These are my financial disclosures. None are relevant. So to DSEC or DMEC, that is the question. DMEC, as we know, gives better vision, quicker recovery, less rejection, and better endothelial cell retention. Of course, we need to have patient considerations, how to choose the correct patient for either a DSEC or a DMEC. And all of these factors should be taken into consideration. What is their corneal status? Do they have previous corneal surgery, such as a PK, a glaucoma shunt perhaps, and of course the surgical view? For DMEC, cases of isolated endothelial cell failure, pseudophakic corneal edema, Fuchs, ICE or previous PK, that tends to be my go-to. I tend to do DMEC in all of these situations. You want to be sure there's sort of minimal stromal edema or some unhappy DSEC patients. If the patient had a previous premium IOL, such as a multifocal IOL, and then developed endothelial cell failure, a DMEC is going to give them better visual acuity. More challenging cases, cases of previous vitrectomy, high myopes who have a deeper anterior chamber, prior glaucoma surgery, or if they need an IOL exchange at the time of your DMEC. It's also possible to do DMEC in these cases. Cases more appropriate for DSEC, if you have very little iris, whether it's aniridia or a partial iris defect or moderately large iridectomy, in that case, it's just make life easier for yourself and do the DSEC, aphakia, an ACIOL, silicone oil. Even if the retina person told you, they swear up and down that they got all the silicone oil out, you know that they are in fact lying. There's still silicone oil to be had. Do a DSEC, make your life easier. Glaucoma patients who have a tube in the anterior chamber, in that case, a DSEC is also preferable. DMEC, of course, requires a good view. And DSEC, you can do a DSEC even with a relatively cloudy view and poor visualization. After a previous cornea transplant, you need to know the differences between DSEC and DMEC. For DMEC, you do have to strip Decimase membrane. Decimase does not stick to Decimase. You have to be careful of that graft-host junction. For DSEC, you don't have to strip Decimase, although I usually do. And I always use about 1 millimeter smaller DMEC or DSEC graft compared to my previous PK. So if I'm doing a graft in an 8 millimeter PK, I choose a 7 millimeter. When you have a aphakia or you've got this is a patient who had previous trauma, had very little iris there. I did a scleral fixated lens, but I did what I call a stay suture, suturing the DSEC lenticle to the previous PK, and I'm glad I did because as you could see on the OCT, the only thing keeping that DSEC lenticle from being on the retina is in fact that stay suture. Unicameral eyes, it is notoriously difficult to get a good air fill, and so you want to keep that in mind. You also want to know if you have a failed DSEC, what was the etiology? Was it rejection, failure? Was there a problem with the surgery? And then you can decide whether to repeat with a DSEC or a DMEC. Patient with who's young, a phakic patient, if you have a good view and minimal comorbidity, then that's a great patient, again, for the doing a DMEC. This is a case of DMEC after DSEC. You'll see I'll go in there, and with this is a little MST forceps, I can just simply strip that DSEC right out. I do stain with blue in these cases because, as you could see here, there was a tag of Decimase membrane that would be really good to remove if I'm doing a DMEC following a DSEC. And then here I'm using just the Gutter cannula. We're going to insert that. This was a deep anterior chamber, and so I use a lot of the techniques to get that DMEC graft opened here, and just, again, just using some of those techniques for a deep AC where I narrow the AC, I tap it, I call it tap and trap, tapping it, trapping it, and we get the graft open, move it in place, and give an air bubble, and goes very well. With DSEC, if you have, again, a more challenging view, an anterior chamber lens, aphakia, or tube shunts, if a patient has previous glaucoma and has a previous glaucoma tube shunt especially, then that's somebody who probably want to do a DSEC on. I used to do DMEC on everything and everyone, and I switched actually in these cases to doing DSEC because these grafts don't last very long. They have maybe a 2 to 5 year, if you're lucky, life, and therefore rather than having the more expensively prepared tissue of DMEC, I tend just to do a DSEC. Also, they tend to have a more limited visual prognosis. This is a patient who had a repeat DSEC after a failed PK, an Ahmed tube, glued IOL. They basically had just about everything except for an RD repair, and hopefully they won't need that, but you can still get a good result. So in summary, how to choose a DMEC or a DSEC. For DMEC, you need a good view. I like doing them as procedure of choice in previous PKs or phakic patients. If there's a failed DSEC with minimal comorbidities, then DMEC is going to be a really nice option for you. And I save DSEC for my more complicated cases. Thank you so much.
If you have any questions from the audience, yes, sir. If you can stand up and speak loudly. If you can repeat the question for the audience who are behind him.
The question was, I believe, whether you do DSEC or DMEC for a previous vitrectomized eye. And I'd say if you're a novice DMEC surgeon, don't choose a vitrectomized eye as one of your first cases. But you can certainly do DMEC as long as there aren't a lot of other comorbidities. In a vitrectomized eye, you're going to have a deeper anterior chamber. And so you're basically going to need to do different maneuvers so that you can get that DMEC scroll open. You can also do a pull-through technique that Dr. Jodmet describes. That's also a nice technique as well. So there's a variety of techniques that you can use in a vitrectomized eye.
You should have come to our session yesterday morning. That was my presentation, correct? Just kidding, but it was the topic. But
yeah, I mean, there's a bunch of, I was about to say Tony gave a lovely talk on that yesterday morning. Essentially, you can do different techniques where you apply pressure, and then what you can do is you can then sort of tap and trap the scroll, and by tapping, doing a tapping technique where you kind of tap up, you release up, then you create kind of a little vacuum and you can get the scroll open. So there are several techniques that you can use in vitrectomized eyes.
So I have two quick questions, and it's both about for DMEC following prior keratoplasty. So in the setting of a prior DSEC that's failed, I'm doing DMEC, I often find there's sort of a fibrotic ring around the edge of the DSEC graft after I remove it. How do you size your DMEC grafts after DSEC? Do you see that fibrotic ring, and if so, do you want to have the graft fit inside of it, or is that something you haven't really seen in your DSEC failures? You'll just use whatever DMEC graft size you want, independent of the prior DSEC graft diameter.
In the setting of a previous DSEC, usually the previous DSEC is about 8 millimeters. I do measure it ahead of time because I'm going to pre-order my tissue. And so if you are pre-ordering tissue, I tend to order a smaller DMEC graft at 7 millimeters. And I find that in general, the 7 millimeter graft is going to fit in, because as I demonstrated in that case, there was a little bit of fibrosis, but also a little bit of decimase membrane that needed to be stripped there, as you know, which is important. And so that's what I do is I specifically order. We have the luxury of ordering from the eye bank to be able to size down, or you can just measure ahead of time and then decide on the size of your DMEC graft, but I tend to size down for that.
And then the second question, in the setting of a prior failed PK, do you ever use OCT to look at the posterior corneal profile? And if you don't see a step at the graft-cellus junction, do you feel comfortable going larger? You mentioned you usually undersized by millimeter, but let's say you have a small PK. Do you ever do OCT to say, oh, here I can actually have a DMEC graft that's the same size as the PK?
I do use OCT. I still tend to be a little conservative because even if on the OCT it looks fine, sometimes when you get in there, I find that it's not as perfect as you might think. And so I still tend to be conservative and size down.
So I guess the only time you don't worry about it is if it's a failed DALK. And I've had a couple failed DALKs. Then, of course, the posterior cornea is smooth. Yeah. Non-functioning, so then you can do whatever size, whatever diameter you want. So great talk. Thank you very much. Our next speaker is Dr. Marta Calatayud, who will be speaking to us on IPCL phakic lens for the treatment of keratoconus. Okay, wonderful.
Well, good afternoon. Thank you for your invitation to share with you my experience in patients with keratoconus with IPCL. You do it? Should I do it?
If you make sure to speak into the microphones and make sure everybody can hear you.
Sorry.
Thank you. No problem.
It's too high for me. I have a pen drive with me. Do you want me to insert it here?
You have it on your laptop?
No, this is not my laptop. Okay, looks like.
If we don't have it ready, can we go to the next speaker, then come back? I want to make sure we try to finish on time.
We have it. Wait. Okay.
Perfect.
Okay. I have no financial interest to declare. I'm sure when we are talking about keratoconus, it comes to our mind a patient with usually male, young male, with high keratometry, thin cornea, and irregular astigmatism, but I'm not going to speak about those patients. I'm going to speak about the others. The ones who perform any additive cornea surgery, like cornea rings or keratoplasty, and they feel that the otherwise successful surgery is a failure because they cannot see. The main cause of this feeling is astigmatism. You, as a surgeon, you are very happy because you see the graph clarity and vision, but the patient says, and doctor, I perform a surgery, I cannot see. So we should try to find a treatment which is safe, predictable, and in only one surgery to match all their needs. Regarding these treatments, I put in bold the most important, but astigmatic keratotomy, if cylinder is very high, is not going to correct the full refraction. And laser refractive techniques are not recommended because there is a risk of endothelial decompensation. However, phakic IOL, for me, is the best option because it preserves the accommodation process. We do not touch cornea tissue. It has a kind of contact lens effect in terms of quality of vision, and we only do one surgery. And this lens is customized to implant always 0-180, and it can be customized regarding the cylinder. So this is a fact. We know that after penetrating keratoplasty, there is a chronic graft rejection process. Even if the graft is clear, there is a loss in the endothelial cell count. Cells become bigger, and there is high polymagatism. But after DALC, it resembles a normal endothelium. There are not too many papers published regarding phakic lenses after DALC or PK. Especially after PK, there is only case reports with complications. So even so, I think it's a good treatment for these eyes. But if we are facing these complications in normal eyes, we cannot afford an oversizing or high bold or low bold in a patient after keratoplasty because it means we will have to remove the lens and implant another one. And this can spoil the endothelium. So I chose this phakic IPCL because I had patients with high astigmatism, irregular cornea. They were not suitable for LASIK, and they were intolerant with contact lenses. The main test we performed was, of course, endothelial cell count and OCT anterior chamber to measure the angle-to-angle distance because in these cases, sometimes white-to-white is a little bit tricky. But for me, it was very important to perform a best-corrected vision test with contact lenses because this is what we are going to explain the patient. This will be our target, okay? To improve 2-3 lines compared with spectacles before the surgery and to reach, if possible, best corrected with contact lenses after the surgery. And of course, we are going to explain them it's a safe method. So let's start with the cases. The first one is a kind of poltergeist. I don't know if you know what is a poltergeist. It's something you see and you cannot explain. It's a male, 35 years old. According to him, He was treated with Intacs and ICL in 2014. But if you check the refraction, there is a -9 cylinder, which is matching keratometry. And two things, there is no central port, and there is a huge iridectomy. So it means either this is an old lens, or it's a plus lens. I don't know. Left eye, he performed penetrating keratoplasty, but even so the cylinder was very high, but his vision correcting was good. So we talked to the patient. We first removed ICL in right eye, then we wait for 1 month to let the eye heal. And then in the meantime, we implanted IPCL toric in his left eye, and then we implanted IPCL toric in right eye. The surprise was that after removing ICL in right eye, this was the refraction, -585. So I really don't know what was this ICL doing there. It was correcting nothing. After implantation, we discovered we implanted it upside down. This is not a common complication, but you can see the low volt and the angles. Even though the vision was good for him and the pressure was normal, because these lenses have many holes to avoid high pressure. And in the lower image, you can see the angle after implanting the lens in the correct position. Uncorrected vision is good, both eyes separate and together. And these are life-changing surgeries for these patients, because this patient couldn't even drive. Another interesting patient, this is a male 17-year-old keratoconus. I performed ALK in 2018. 2 months later, he had a trauma. Descemet's membrane was preserved, but he was resutured in this area where you have the arrow. And in the right eye, you can see he's wearing a broken scleral contact lens, even though his vision is very good, and he has papillary reaction in the upper eyelid. So in August, we performed DALK, and after removing the stitches, you can see there's 11.2 astigmatism diopters, and it's more important in the area that was resutured. This patient developed posterior cataract, polar cataract, so I performed the surgery. At that point, we were facing pandemics, I think, 4th wave, so I couldn't find a customized lens for him. This is the post-operative result, not so bad, but 6 months later, after posterior YAG capsulotomy, suddenly everything changed, the vision reduced, and the cylinder increased. So it means we have a tilting here. And we have to solve this, because this patient cannot see. In this case, the most predictable procedure was implanting toric IPCL. I recommend you to get maximum dilation, which is not the case. This IPCL size is 14. Perform a proper tunnel incision to avoid any stitches in the postoperative. Use tons of viscoelastic, because we must protect this endothelium. Big marks for alignment, because as you can see, there is a keratoplasty scar, and sometimes it's very difficult to orientate the lens, and administer Diamox at the end of the surgery. So this is the final result. We have our cornea with 11 diopters astigmatism. We have our tilted lens. You can see the posterior capsulotomy, and this is IPCL, correcting cornea and tilting. Uncorrected vision 0.7 with some halos at night, which he's happy with. Another patient, I'm not going to talk about the right eye, he's very happy with his right eye, but in left eye, we have the same problem as in our previous poltergeist. He implanted Intacs and ICL in 2004, but his vision is uncorrected 0.2, best corrected even with contact lenses 0.4. So these Intacs are not working, and the phakic lens is not working. We must remove all. But in these cases, my suggestion is to leave nothing to chance. You should count your cells. You should measure the depthness of the ring. So if we can remove the anterior cornea and the ring, we will have 100 microns area, and we can position our graph over it. And regarding the visual acuity, it will be the same as when you perform an ultra-thin DSEK. I'm not going to stop explaining you this DALK procedure, only telling you that in these cases there is a fibrous tissue surrounding the rings, and it's very important to dissect over and under the ring to remove it, okay? After removing the rings, we kind of polish the center of the cornea, And this is the final result. After 1 year, you can see in the upper image there is an 80 microns remaining stroma in the upper area, but the center is clear. So comparing pre-DALK with post-DALK, there is high astigmatism, but best corrected vision is better. Again, leave nothing to chance. Measure everything you have to measure. You can see now our cell count is 1333. And finally, 14 months later, his uncorrected vision is 0.8, improving to 0.9. This is the bold. I'm going to run. This is another patient. She came because of diplopia.
You can please wrap up. Thank you.
Yeah. And this is another interesting case. In this patient, we had PKP in right eye, DALK in left eye. So PKP means low endothelial cell count. DALK means normal endothelial cell count. We implanted IPCL, but there was a toxic anterior segment syndrome. You can see the pseudo-hypopion here. We increased the dose of cortisone, and he improved, and after 1 week, vision was 1.0. And the endothelial cell loss is not so important. This is a patient with epithelial dystrophy. So I cannot draw an important conclusion from my series because my numbers are not Indian numbers. But I think this IPCL is a precise, safe, and reversible method to try to treat high astigmatism after keratoplasty. Uncorrected vision equals best corrected with contacts, but you need to be an experienced surgeon. So it could be the missing final piece of keratoconus puzzle treatment. Thank you.
We're a little bit over time, but just very briefly, is this available in India? Does anybody here know, or do you know?
Yes. In fact, it comes from India.
This is actually manufactured in India?
Yeah, in
Excellent.
India and UK. I think they are going to open another factory in Egypt.
Ah, okay.
Yes.
What's that? Care group, okay.
It
Very
was
good.
approved in UAE 2 years ago.
Switch. Very good. While we're transitioning, any other questions while we're making the transition? You mentioned that dilation has to be good. Excuse me, how much, Martha? Martha? You mentioned that dilation has to be good. Is there a minimum dilation that is required in order to consider a patient for the IPCL?
No, the problem is that I always use finale before the surgery because with this I get a better dilation. Otherwise, if I start to manipulate the lens, then the people will become
Right.
gross, and then it will be very difficult to cut.
Very good. Thank you. Our next speaker is Dr. Arundhati Anshu, and she'll be speaking on DSEC, management of complications and long-term outcomes.
Hi everyone. I've been following the talk in the morning about when to do DSEC and when to do DMEC. I think this is just nice because despite the fact that there has been an increase in number of DMECs the world over, we still continue to do DSEC for a select group of patients, and especially when you're a novice surgeon, for the complex cases, it's best to stick to DSEC, which is a lot more easier to manipulate in the eye. So I'll be going through some of the complications that are encountered in DSEC, which could be intraoperative or postoperative, both in the early period as well as in the late stages, and how best to manage them. Fortunately, with the advent of EK, suprachoroidal hemorrhage is quite uncommon. Manual donor dissection, there's always a risk of perforation, but now we've moved away to doing it automated, and so the risk is much lower. But even then, you can still get perforation, so now we get the eye banks to do it. That helps to reduce some of the stress on the surgeons, and so we tend to get a lot more predictable donor corneas in patients going for DSEC. There is always some problem with posterior lamellar donor preparation because we know when we have the cut created, there is a difference between the central and peripheral corneal thickness, which is also responsible for some of the hyperopic shift. These thick edges, especially in our Asian eyes, can be sometimes challenging, resulting in angle crowding and pupillary block. But with thinner donors, these problems can be mitigated, and of course with DMEC, this does not arise at all. Some of the common complications in the early stages is conversion to PK intraoperatively if the patient has a primary graft failure. In our early series, the risk of conversion to PK was very low, And there is this whole host of papers that have been published on the rates of dislocation following DSEC. In our series, in the early stages, we found that our complication for DSEC was less than 1%. And as you can see, the variation in dislocation rates, depending on the type of technique that you use for doing DSEC, as well as in the early learning curve when there is a higher rate of dislocation. Some of the things that have been introduced to reduce this risk of dislocation is venting incisions, scratching the periphery of the recipient bed, having a complete air fill, massaging any fluid from the interface, especially through the surface drainage venting incisions, leaving a full air fill at least for 6 minutes. Now, a lot of studies have shown that you need a minimum air fill for 6 minutes. And now, in recent years, I don't tend to remove any of the air, and I leave the eye with a full air fill and have a PI there so that we know that the patient is not going to get a pupil block post-op. Of course, you have to keep in mind that with venting incisions, there is always a risk of epithelial ingrowth and infections at the site of the venting incisions. Pupil block glaucoma, again, variably reported in literature. We have very low rates of pupil block because we tend to do a PI for all our cases. And I think the world over, a lot of the surgeons have now started doing PI, resulting in a lower risk of pupil block post-DSEC surgery. Iatrogenic graft failure or primary graft failure, it used to be a lot more in the early years when DSEC was first started because of the steep learning curve with improvements in techniques and technologies. Now, of course, the rates of graft failure have gone down significantly. And in our series on the endoglide, the rates of graft failure were less than 1%. So we also looked at a study to see what were the graft failure, donor and surgical risk factors for graft failure. We looked at several parameters. And we found in a multivariate analysis that the only thing that stands out is the donor insertion technique as a significant risk factor for iatrogenic primary graft failure. What about late complications? Graft rejection, again, variable reports in literature from 2 to 45%. In our series of more than 600 cases in the early phase was about 10% of cases. And compared to PK, a lot of these patients can be asymptomatic or have very mild symptoms that may sometimes be mistaken for something which is innocuous and not a rejection. So, and not all of them have KPs. They may have a little bit of edema, and rejection line is very uncommon following a DSEC graft. And if it's not treated in a timely manner, more than 7% to 10% of patients can progress to failure. So this is a very good paper published in 2009 by Price et al., who showed that the probability of a rejection episode was the highest in the first 2 years of surgery. So at our center in SNEC, we make sure that we follow these patients closely for the first 2 years of life, 2 years post-transplant, at least at 3 to 4 month interval. And thereafter, if they have remained stable, we can see them on a yearly basis. Of course, this study also showed that African Americans had higher risk compared to Caucasians in eyes with pre-existing glaucoma, or steroid-responsive ocular hypertension, were also increased risk of rejection. What was also interesting in this study was there was no increase in rejection when the fellow eye was grafted within 1 year. So there has been a shift or a trend to doing the other eye within 3 to 4 months post-surgery, as long as the first eye has been stable. This is another paper by Wu et al. In AJO that again showed that the risk of rejection was highest in the first 2 to 3 years post-transplant when you need to follow them up. And a cessation of steroids had a very high risk of increasing the risk of rejection. So I think the world over, a lot of us still will continue these patients on at least minimal low-dose steroids in the long term. How do we manage these patients with rejection? I think high vigilance, counseling, and making sure that you have a good support system in the hospitals to make sure the patients can come in if they have any symptoms, and of course, intensive topical steroids. A lot of these patients they can recover just with topical steroids alone. Occasionally, if there is significant edema, they may require oral steroids as well. And these are some of the differential diagnoses to keep in mind when patients come in with symptoms and signs suggestive of rejection, late graft failure, sterile endophthalmitis, epithelial downgrowth. Of course, you can do, if you are in doubt and you see a white membrane on the iris in epithelial downgrowth, an argon laser test can be useful. And of course, in our part of the world, CMV, because a lot of cases of rejection may actually be mimicking a case of CMV. So this is our first few cases of CMV post-DSEC. We've had several now, more than at least 50, 60 cases of CMV post-DSEC or DMEC surgery. And so this is something that we always keep an eye on. If a patient has got symptoms and signs suggestive of rejection with high intraocular pressure, have those typical coin-shaped lesions, or even pigmented KPs, not just in the graft, but also beyond the graft-host junction, it's highly suspicious of CMV, and it's important to tab these patients either preoperatively if you're going to get this patient to surgery, or at least during the surgery, and then monitor them post-op. How about raised IOP? I guess we see a lot of the patients with DSEC, at least a third of them develop. And these are some of the questions we want to know when you have a patient with raised IOP. What's the incidence of high IOP? What is the effect of raised IOP on post-DSEC patients with pre-existing glaucoma? And what are your management options if they develop post-DSEC IOP? So in short, if a patient has had DSEC, it's very comparable. So a third of patients similar to PK can develop a high IOP post-operatively, and there are no specific risk factors that have been identified for post-DSEC glaucoma yet. And what about IOP after DSEC? Again, over 2 years, higher failure rates if patient has got pre-existing glaucoma versus no glaucoma. And if you need to do a glaucoma surgery post-DSEC, most often it has been suggested that tubes are not good, especially for post-PK. It was suggested that a tube is a better option because these are high-risk eyes. But we realized that I think a trabeculectomy is a good first attempt in patients who need glaucoma surgery post-DSEC. Again, cataract formation and late endothelial failure. So to conclude, early complications can be improved with newer techniques, with resultant reduced dislocation rates and IPGF. Late complications can still happen even with lamellar surgery, so it's important that you have long-term follow-up to ensure that the patients have the best outcome.
Thank you very much.
Thank you.
We have time for maybe a question from the audience. I have one. You said that you had showed a series of DSEC cases at SNEC, and the only risk factor for graft failure was the insertion technique. I find that very surprising because pretty much every other big series, including, for example, the cornea preservation time study, which was 1,300 cases, showed what we all know, which is that prior glaucoma surgery is the probably most important risk factor, but others, such as presence of ACIOL, intraoperative complications, etc. Was that series, did that exclude patients from prior glaucoma surgery or ACIOLs, other known risk factors for failure? Early failure.
You're talking about primary graft failure.
So primary graft failure.
Yes, yes.
Got it. Okay. Thank you. Okay, I was trying to reconcile that with the rest of the other literature, so that makes sense. Thank you for.
No, it's primary graft failure.
Thank you for explaining that.
Yeah.
Appreciate that. Very nice presentation. Our penultimate presenter is Dr. Takefumi Yamaguchi, who will be presenting to us on application of visual optics to various corneal diseases, tips to achieve better vision after a corneal transplantation. Okay. That's what we have printed. On the slide here, it looks like management and strategies, challenging cases. So take your pick.
I changed my topic. So, thank you for giving me this great opportunity to present my recent challenging cases today. So, I'd like to talk about the challenge and show you as extremely challenging cases in Japan from diagnosis, management, and treatment to achieve better vision. First case is a 46-year-old male with bilateral neurotrophic keratopathy due to herpetic simplex keratitis. He had active atopic dermatitis and underwent anterior laminar keratoplasty previously for treating corneal perforation in other hospital. His visual acuity was 0.01, and he had extremely thin cornea, as shown here. It's a high-risk case for PKP. How will you treat him? To avoid postoperative leakage, I selected manual top hat-shaped PKP with postoperative systemic immunosuppression. Top hat-shaped graft was prepared manually using artificial anterior chamber and crescent knife. Then I selected the small diameter graft of 6.75 to avoid graft rejection with wider endothelium with 8.0 millimeter trephination. The surgery was very successful without any complication, achieving excellent visual acuity of 1.0 with minimal astigmatism. And systemic cyclosporin A was prescribed to prevent graft rejection. However, 1 year after PKP, the cessation of cyclosporin A led to graft rejection and endothelial failure. What will you do for him? A high-risk eye. I selected endothelial keratoplasty combined with cataract surgery. After DSEC, he kept excellent vision, and now no need for immunosuppression. This case suggests important future potential therapy, that is cell injection therapy. It's been approved by Japanese FDA and will be available from this June, covered by Japanese health insurance. I expect that treating such high-risk cases will change in near future. First, PKP, potentially preserved cryografts, then cell injection, much lower risk for graft rejection. But PKP technique with minimum astigmatism will be required. Next case is 78-year-old female with bilateral poor vision due to graft failure 30 years after PKP for lattice dystrophy. You can find clustering keratopathy in the left eye, in which candida was identified. How will you treat her? I selected PKP combined with cataract surgery in the right eye. I'd like to show you the surgical video. I couldn't see nothing inside the eye, but managed to complete CCC, but very difficult to perform phaco. I decided to remove opacified stroma, leaving the membrane, then perform phaco and IOL insertion into the capsule bag like this. This is an easy, very useful technique when you perform PKP combined with simultaneous cataract surgery, but take care keeping the bottle low. 1 month after PKP, her vision improved to 0.7, and now he came to see me, walking by herself. Managing such difficult cases successfully, I sometimes experience miracle. This is 55 years old male, a medical doctor, gastroenterology specialist. He was referred to me from a very famous cornea surgeon in Japan. It's very peculiar because he can perform cornea transplantation himself. Slit lamp shows like this, and the patient used a long-term steroid eye drop for posthumous Straussman syndrome. What's the diagnosis and how will you treat him? Diagnosis would be easy, crystalline keratopathy. Never perform PKP in such cases. The surgical outcome will be devastating. As expected, candida was identified from culture. I advised him to stop steroid and start antifungal treatment, but something is wrong with him. His cornea was perforated. Why? What do you think of the reason for this? Despite the successful AMT, amniotic membrane transplantation to close the perforation, his condition got worse and worse. The reason turned out to be that he is a medical doctor. He prescribed steroid eye drop for himself without my permission and did not follow my prescription of voriconazole because voriconazole eye drop was itchy, he confessed. In such condition, how will you treat him? I performed scleral corneal transplantation. This is a post-op slit lamp, and his vision is excellent with minimum astigmatism of only 1.5 diopter, and his vision is 0.7. This slide shows the AI installed in iPhone to diagnose corneal diseases. No need for any attachment. And it's been published in British Journal last month. Please read this article if you are interested. So next case is 77 years old with bullous keratopathy, and he was referred to me for the treatment of. I would like to skip this case because of the lacking of time. So this case is very successful after 2 PKPs. His vision 1.0 without any spectacle correction. So this case is very difficult to diagnose. 5 years old bilateral congenital corneal opacity, her vision was only 0.04 bilaterally, was the diagnosis. So I'd like to skip these slides. So do you know why the cornea is transparent? It's because the collagen fiber is in the correct position with uniform distance line like this. And decorin gene plays an important part, keeps the distance between collagen. Decorin is a causative gene for the stromal dystrophy. I performed a talk last month. Pediatric PK is not good because of serious postoperative complications such as graft rejection, refractory glaucoma, and infection. After talk, one week after talk, her vision improved from 0.04 to 0.4. So in conclusion, transplantation is sometimes challenging. However, miracle can happen if you consider the best treatment as always. Thank you very much.
Thank you very much. I'd like the next speaker to come, the last speaker to come to the podium if they would. And for those here for the next session, I want to let you know we started 15 minutes late, and we're only going to finish 5 minutes over. So we've taken 10 minutes less than our allotted time. I want to be fair to the speakers here. And is our next speaker good is ready. While you're walking, you mentioned that ex vivo expanded endothelial cells have a lower risk of rejection.
Yeah.
And has that been demonstrated?
Not yet, but I believe that happens in near future. It's very promising.
Yeah, I know no cases have been reported, but we'll have to have more clinical evidence, I think, before we can conclude that. But certainly maybe a potential advantage of ex vivo expanded endothelial cells as compared to a traditional DMEC procedure. So very nice presentation. Thank you.
Thank you.
Our last speaker is Dr. Ayan Mohanta, who will be speaking to us on a topic. No, actually, it's not. Dr. Biswas is presenting instead on a topic. The title is Blink Meat.
Yeah. So I'm sharing my cases, 2 cases for discussion on the dry eye,
Wonderful.
Evaporative dry eye.
Thank you. We look forward to it.
Thank you. Thank you. Thank you very much. And evaporative dry eye, and we start with the case discussion simply because these are the cases that we find every day in our clinics. Because of the heavy load of patients, we tend to miss evaporative dry eye. But let us discuss these cases, which are not so difficult to decipher, and at times just clinically attending and seeing the clinical aspects, you can understand that this is a case of evaporative dry eye. So this was a case of a 40-year-old male who is an IT professional and presented with complaints of tiredness and irritation of the eyes after prolonged duration. And these IT professionals, of course, work about 8, 10, 12 hours on the screen, on the laptops, on the computer screen, as well as on the mobiles. So he complained of stiffness of the neck and shoulder pain and backache. So these duration of the symptoms were for 4 to 6 months, and we assessed and saw that the T-BUT was just about 5 seconds, and the vision was 6/9. He used to be irritated because the vision would fluctuate, and he had to close his eyes, splash water into the eyes, and then go ahead. And Schirmer's was 8 and 7 in the right and the left eye. So we did these investigations, and it was diagnosed as computer vision syndrome. So Sustain Complete is what we used as a lubricant, and 3 to 4 times, and we asked this patient to give it even more if required, and especially on strenuous days. So the outcome started from day 1, and gradually it improved, and in 3 months treatment, the Schirmer's was 18 and 16, right and left eyes. Now, the second discussion is an elderly lady, and she complains of eye irritation and watering, and these symptoms are for 4 to 6 months. Now, Here, the evaluation, the T-BUT is just about 4 seconds, and the Schirmer's is 24 and 23. And the BCVA is 6.9. Now, we started this patient also on Sustained Complete. I have no financial interests, wish I had, but this is something that I really rely on, and especially for these cases whom clinically we diagnose as evaporative dry eye. And the outcome after about 3 months was the Schirmer's improved to 18 and 16, with the T-BUT improved to 10 seconds, and the patient had a lot of relief from the dryness. Thank you very much.
Is this yours?
That's his name? Is that who that is?
Taking ahead from what Dr. Biswas has said, I will be stressing on the importance of blinking in order to prevent ocular surface disease. So this is my financial interest. So overall prevalence of dry eye disease ranges widely, approximately 50% in different population-based studies. If we look at the prevalence of dry eye in India, amongst the mobile, computer, and tablet users is almost 89%, and amongst diabetes mellitus patients is almost 76%. So these are the types of dry eye we all know: aqueous deficient dry eye disease, evaporative dry eye disease, and mixed dry eye disease. So 4 out of 5 dry eye patients have some form of evaporative or lipid deficient dry eye. In a large demographical study comprising of almost 14.5 lakh patients in India, 21,290 patients had symptoms and signs of dry eye disease, of which it was seen that a mixed dry eye disease and evaporative dry eye disease comprise almost 4/5 of them. So these are some of the risk factors for evaporative dry eye. Poor blink rate and incomplete blink can lead to increase in tear evaporation. The blink is essential to preserving tear film homeostasis. During a complete blink, the mebum is released from the oil glands to the lid margin for dispersion onto the tear film. When the upper lid does not meet and overlap the lower lid, less force is exerted on the glands, resulting in mebum expression into the lower lipid reservoir. Uneven distribution of the lipid layer across the ocular surface, and instability of the tear film, and a lower tear breakup time, and increased tear film evaporation. So if we look at the digital eye strain and evaporative dry eye disease, decreased blink frequency and increased incomplete blinks lead to 4 times evaporation of the tear film, ultimately leading to hyperosmolarity, inflammation, ocular surface damage, and tear film instability. And this goes on and on and on. So MGD is the most common cause of evaporative dry eye disease. Meibomian glands in those patients drop out, they block, or they get inflamed. Stasis of the mebum inside the gland causes proliferation of the bacteria and mites, increased lipid degrading lipases and esterases, increased viscosity and melting temperature of the mebum, decreased secretion of the mebum on the surface of the tear film, and completing a self-sustaining MGD cycle. So if you look at the diabetes and evaporative dry eye disease, decreased corneal sensitivity, which reduces the blink rate, leads to destabilization of the lipid layer of the tear film and results in increased excess evaporation. Also, higher meibomian gland scores, lower mebum expressibility, and lid margin abnormalities contribute to the dry eye factor. 4 out of 5 patients, as I already told, have evaporative dry eye component. Hence, optimal identification and management of evaporative dry eye is essential. World Council of Optometry recently published a dry eye wheel to simplify screening and management of dry eye. I'll be focusing on this part of the bronze ring, which consists of validated questionnaires, detection of comfort time after blink test, blink rate and completeness of blink. Alcon has developed a device, a very simple device to count how many seconds the patient is comfortable after one blink. So if it is less than 10 seconds, repeated 3 times, is indicative of dry eye disease. And while examining the patient, you should look at the completeness of blink when the patient is sitting on the slit lamp, and to find out whether the patient is blinking completely or not. If not, then he has to be counseled about proper blinking and its good effects. Coming to the management, the lipid layer normally ensures decreased aqueous evaporation by 90 to 95% and decrease in the surface tension of the tear film phase by 25%. Patients without a visible lipid layer have found a 4-fold higher rate of tear film evaporation versus with a non-continuous lipid layer. Emollient drops are thus developed. So in lipid-based artificial tears, useful in dry eye disease of low blink rate and incomplete blinking, a step closer to natural tears, longer lasting lubricating effect, minimal interference with vision, more effective than aqueous tears, effective in all types of dry eye. Whereas traditional aqueous artificial tears, temporary symptomatic relief, they do not target the underlying pathophysiology. High viscosity increases efficacy but decreases tear clearance and blurs vision. So Cystin Complete works on all layers of the tear film. The HP Goer forms a hydrophilic meshwork cross-linking with the muco-aqueous layer, creating a protective elastic matrix. Nanosized lipid droplets migrate to replenish the top lipid layer of the tear film, repairing the gaps and providing complete coverage for the lipid layer. Coming from one of the studies by Craig et al., it was to compare the efficacy of Cystin Complete and Cystin Ultra for management of dry eye disease to determine the therapeutic profile for clinically significant improvements of signs and symptoms, including the magnitude, to assess whether the clinical outcomes are influenced by baseline dry eye disease subtype or severity. There was 134 patients in the study, out of which eligible patients were 99. Cystin Complete was given in 50 and Cystin Ultra in 49. There was equivocal response as far as dry eye questionnaire was concerned on OSDI, DEQ5 and Sunday. The tear film quality was improved in both of the eye drops from day 120 onwards. But if we look at the tear film lipid layer, Cystin Complete and Cystin Ultra were similar up to 90 days. From 90 days onwards, the Cystin Complete, it showed a marked improvement of the lipid layer thickness in the Cystin Complete group. To conclude, evaporative dry eye can occur as a result of anything affecting the eyelid. 4 out of 5 cases of dry eye are evaporative dry eyes. Lipid-based artificial tears are effective in evaporative dry eye as they mimic natural tears and replenish lipids. Cystin Complete works on the lipid layer and muco-aqueous layer of the tear film and offers solution to all types of dry eye patients. Thank you very much.
Thank you, Dr. Mahanta, and thank you for all the speakers in this. I think it was an excellent session on cornea challenges, and we'll turn it over to the next speakers. Thank you.